to endure my English, or my Americanized English. So once again, thank you very much for the opportunity to speak. It's an honor to be a part of this program and to learn about Egyptian culture here. So I've been tasked with sharing you an update on progressive MS trials. I'll focus on the phase 3 trials, what we have found and what we have learned about how to do these trials. So here are my disclosures. I'll just divide my thoughts into a couple different areas and try to outpace that counter as it counts. One, what is progressive MS? What have we found in the phase 3 trials? What have we learned about how to do the phase 3 trials? And two brief stops at what about symptoms and an introduction to the International Progressive MS Alliance. Given the multicultural nature of this meeting, it seemed appropriate to share a little bit about the Progressive MS Alliance. So first, what is progressive MS? Go back to this descriptive, which divides MS into active and progressing, de-emphasizing the relapsing remitting versus secondary progressive, although our regulators are still sort of caught in that. And it focuses on, is there active inflammation? And I'm depicting that here with a red overlay. And is there ongoing progression? And I'm depicting that here with a green overlay. So active focal inflammation, relapses, new lesions in MRI, or progressing disease. So what does that mean? Well, this is an old depiction back in 2012 that shows the focal inflammation in red here, the new waves of lymphocytes entering the CNS, new lesions on MRI or new episodes. And then in green is something else, trapped inflammation, meningeal inflammatory aggregates, slowly expanding lesions, and the like. This is a more updated consideration. On the left is the new waves of inflammation, and then disease injury, the green in the middle, that large green triangle in the middle, and now introducing age-related neurodegeneration. That may be a third factor. I will ignore that a little bit and focus on that middle triangle. This also may represent metabolic derangement, so alterations in the mitochondria and the ion channels being redistributed in chronically denuded axons. And then this paper from Nature Review Neurology, I'll defer you to a very nice description of the various compartmentalized inflammation mechanisms that might be going on. But for the remainder of this talk, I'll simply refer to the red pathology, the focal inflammation, infiltrating lymphocytes, clinical relapses, and then the green pathology, which I don't think we really understand what is the true driver of progression in MS. Is it compartmentalized inflammation? Is it metabolic derangement, mitochondrial exhaustion, something else other than that focal inflammation? So given that context, what have our phase 3 trials found? Well, as you're all well aware, and this is already outdated in that we don't have the latest anti-B-cell therapy listed on here, a number of therapies that have been approved for MS. Which ones in progressive MS? Of course, here are only 3. 𝐻𝐿 or novantrone, which we generally don't use very much and don't think really affects that green pathology. And then ocrelizumab and siponimod. Let me dive a little bit into some of those trials. So first, this is a very old trial of 𝐬𝐩𝐨 acetate in primary progressive MS, the PROMISE trial. And you can see that the Kaplan-Meier curves are nearly superimposed, a similar rate of progression of disability in the placebo as in the 𝐬𝐻𝐨 acetate. How about fingolimod, the INFORMS trial? 800 patients trial in primary progressive MS, and you can see that there was no benefit of treatment on progressive disability. So a similar progression of disability, whether one looks at EDSS alone on the bottom, or the composite of EDSS plus some additional outcomes, 25-foot walk and 9-hole peg test. I'll come back to this composite concept in just a moment, but you can see that there is essentially no meaningful impact on progression of disability. Those were the negative trials. How about the positive trials? Well, we had the oratorio trial of ocrelizumab in primary progressive MS. The graph on the left is probably well known to you all. A hazard ratio of 0.76 or 24% slowing in sustained progression of disability in the treated patients compared to the placebo. But when you break this down by baseline gadolinium and baseline age, what you can see is the patients without gadolinium at baseline did not have much of a treatment effect, a much diminished treatment effect. Similarly, baseline age, the older patients, and I'm saddened to find that that is defined as over age 45, so now I'm feeling quite old, being on the other side of that. So those that are over 45 also had a much diminished treatment response. Now, this has not been published in a peer-reviewed paper, unfortunately. That's why I like to show it, because it's an often unrecognized aspect that patients without gadolinium enhancement or are older at baseline much less likely to show a benefit with treatment with ocrelizumab. Turning to siponimod, a large trial focused on secondary progressive MS and a hazard ratio of 0.79 or a 21% slowing of sustained progression disability. But I'm happy to say this paper in the original pivotal report published a breakdown of the different subgroups. And you can see that those without relapses, again, had a little bit less of a treatment response, closer to 1, than those who had a relapse in the 2 years prior to the trial. Similarly, gadolinium-enhancing lesions, those without, had a somewhat diminished response. Those who were younger, those with a those with a higher EDSS, also a differential impact. So those who had less inflammation, were older, were more disabled, each of those had a decreased likelihood of responding positively to treatment with siponimod. All right, what about masitinib? So this was a 600-patient trial. It was done a little bit differently in that it was looking at average EDSS, and one can see that in the placebo there was an increase in EDSS compared to those treated with the masitinib, 4.5 milligrams. So this was encouraging, although when you look at some of the subgroups, now when you look at the 6 milligram primary progressive group, it looks like the placebo patients did better than the treated patients over time, and then they superimpose and sort of have no difference over time. So a little bit mixed between the doses and between the type of MS, either primary progressive or non-active secondary progressive MS. So this is moving forward with a replication phase 3 trial to further understand how this drug truly impacts progressive MS. How about natalizumab, the ASCEND trial? So this is a large trial as well, 889 patients, 2 years, placebo-controlled. In secondary progressive MS, the primary outcome was a multi-component progression of EDSS, 25-foot walk, a 9-hole peg test. What one can see is that the multi-component outcome showed no treatment effect of natalizumab on progression, although there may have been a suggestion of benefit on 9-hole peg test, but not so much the 25-foot walk and EDSS. How about MD-1008, high-dose biotin? I mentioned that earlier today. The initial phase 3 trial was 1 year looking at improvement of disability. So the primary outcome, sustained improvement on EDSS, and at 12% of the patients with treatment had an improvement, 0%, surprisingly low proportion of the placebo group, so there was no placebo effect. However, then a larger, longer trial was subsequently done, 642 patients in progressive MS. And as you can see, no benefit, no improvement on the component or the subcomponents over time. And so this treatment has now been abandoned, but introduced an interesting idea of looking at improvement of disability, not just slowing of progression. So let me walk through each of these. No, I'm not going to walk through each of these trials, but this is a summary highlights the number of trials that are going in progressive MS are at various stages. And so I think this is a cause for excitement that there is a lot going on, a lot that we are expected to hear from over the coming years. So how do we do these trials? So that's just a brief highlight of how the trials turned out, but what have we learned about how to do phase 3 trials in progressive MS? Well, one, which clinical outcome? I referenced earlier that the 9-hole peg test looked promising with natalizumab in secondary progressive MS. And indeed, the same outcome, 9-hole peg test in oratorio, the ocrelizumab primary progressive trial, also showed some benefit, and interesting, less of an impact of the baseline covariates. So less of an impact of age, of baseline EDSS, suggesting that maybe 9-hole peg test is something that is more accessible, more treatable in patients with progressive MS than the conventional EDSS and 25-foot walk and others. So further attention on arm function, which of course is a very important aspect of function for our progressive MS patients. How about composites? There are a number of trials that have looked at different composites. Composites meaning combining together EDSS, a standard outcome, with things like 25-foot walk, 9-hole peg test, and our cognitive measures. And just showing an example here of, I showed earlier, of fingolimod in primary progressive MS. And although the study was negative, what was encouraging is that over 70% of patients progressed. So over 70% of patients contributed to the outcome, showing that this can be a powerful way to assess patient population. Also combining neuroprotection with inflammation. I think we need to address both the red pathology and the green pathology. On the far right is age-related. I'm not sure how to address that, living healthy lives for helping with the age-related aspects, but certainly treatments that address both the red pathology, focal inflammation, and the green pathology, whatever else is driving progression, I think will be important aspects for it. How about improvement? Well, I mentioned to you just previously about the high-dose biotin trial looking at improvement. And although the encouraging results from the first trial were not confirmed in the larger, longer trial, but nonetheless has suggested, well, maybe we can look at helping our patients get better, not just trying to slow down their decline. One caveat to that is shown here, and this was a putative remyelinating molecule, apacitinib, that was looked at in progressive MS, and using a multi-component improvement, trying to measure improvement, what they found here is in the placebo group, about 50% improved. So when your placebo group has 50% response, that suggests that maybe you're going to have a lot of noise in this outcome. So exactly how to harness improvement in disability and in a way that we can measure the benefit of a drug separate from placebo, I think we're still trying to figure out. This is a summary of the current phase 3 trials in progressive MS, these are the ones I'm aware of. So one in ocrelizumab and 𝐻-𝐸 each, one in fenebrutinib, a new BTKI inhibitor, two in tolebrutinib, masitinib, and simvastatin. Now what you'll see is that many of them are only using the confirmed EDSS progression. Few of them are using a composite. I've heard mixed comments from the regulators as to whether they will accept composites. I heard one EU regulator say we don't accept composites, we only accept EDSS, which would explain why all of these have just EDSS as their main outcome. And then why do these have a composite? Well, maybe because they're already approved drugs, they don't need to have additional indication from a regulator. But nonetheless, these are the big trials that are ongoing, and we keep an eye out for their results in the next few years. So what about symptoms? I'll take just a brief stop here about symptoms to mention the importance of symptoms to our patients. It's been a challenging area for us to study in phase 3 trials. but I will point out this paper that was a review and opinion piece put out by the International Progressive MS Alliance that identified 4 symptoms that were prime targets or seemed to be most amenable and in need and measurable and treatable for progressive MS or in patients with progressive MS, and that is fatigue, mobility and upper extremity impairment, pain, and cognitive impairment. And so at least this paper was encouraging focused attention on those 4 symptoms in progressive MS as areas of unmet need and great opportunity. So finally, the International Progressive MS Alliance. At a meeting like this with much global collaboration and people coming together, I want to make sure people are aware of this group. This is a global collaboration of MS organizations, researchers, healthcare professionals, industry, companies, foundations, donors, and people affected by progressive MS. It's a very broad-based organization working together to address the unmet needs of people with progressive MS. Its mission is very simple: to accelerate the development of effective treatments for people living with progressive MS to improve their quality of life. Their activities are a number of different activities, funding specific research projects, organizing and running workshops and conferences, and also convening activities such as interacting with regulators to understand their needs and their expectations. Governance is through a scientific steering committee, which I am honored to be chairing for the next few years. My colleague with 𝐬𝐩𝐸 from Canada is the vice chair. There's an executive committee, which are the senior leaders from the MS societies, which are part of that. There are a number of groups that have come together, the managing members, which are the MS societies that are shown here. There are a number of MS organizations from around the globe that are a part of the alliance as well. And then there are donors, there are foundations and trust members that have joined together and are providing funding and organizational support. In industry, there is a forum of industry. Say Novartis, who's a sponsor here of this meeting, is one of the members, and indeed their representative is the chair of the industry forum. And there are some associate industry members as well. I won't go through this slide. There's a long list of things that the organization has done dating back to 2010 and is continuing to do in terms of funding research, putting out papers, convening workshops and congresses to try to identify, develop, accelerate the development of therapies for progressive MS. So in summary, several recent positive phase 3 trials have been encouraging, but they do appear to be driven a lot by the benefits in patients with focal inflammation, with the so-called red pathology, with unclear impact of other progressive MS mechanisms that I've called here the green pathology. Different phase 3 trial designs and outcomes have been proposed for progressive MS, which we think are increasing the study power and efficiency of the trial. How the regulators accept them remains to be seen. We don't know exactly which trial, and it may in part depend upon the mechanism being targeted. That said, most of the ongoing phase 3 trials are utilizing the traditional approach, which is trying to slow the progression of PDSS. There's increasing attention towards MS symptoms, although the symptom trials remain few, and global collaboration is critically important as we try to tackle the very big problem of progressive MS. With that, I would acknowledge the contributions of many people living with progressive MS who have joined together in our trials to help us try to find treatments for this disease. With that, I'll stop and thank you very much.